Good afternoon, ladies and gentlemen. My name is Alessandra Fanciulli from the Medical University of Innsbruck, and it is my pleasure today to discuss the journey that a person living with MSA might experience. I will start this discussion with a case, the case of a fainting librarian, not actually the librarian of this Stinktzen Florian in Upper Austria, but was just to show you the beauties of the country I'm working in. And this was a 67 years old gentleman who first reported episodes of nocturia and urinary urge back in 2005. 2012, he had his first syncope episode, and the second one few years later, 2015. But it was first in 2021 that, due to increased orthostatic intolerance, he was referred for cardiovascular autonomic function testing to our center from elsewhere. Back then, he had no relevant comorbidities, no medication, and a negative family history. This was his TIL test examination. So the upper line is the heart rate, the thick blue line underneath is the blood pressure. And you see that when changing from the supine to the upright position, he had a severe fall in blood pressure, especially systolic blood pressure. And this qualifies for orthostatic hypotension, which is by definition a fall in blood pressure more than 20 to 10 within 3 minutes in the upright position. Once orthostatic hypotension is diagnosed, the doctor has the task to distinguish between non neurogenic causes of orthostatic hypotension. This might be, for example, aortic valve stenosis or cardiac arrhythmias, or dehydration or blood pressure lowering drugs. And this is sometimes tricky because it is not only about antihypotensive medication, but also some medication which you might get prescribed for other reasons, for example, for mood, sleep disorders, or pain, or other kinds of. These neurogenic causes of orthostatic hypotension needs to be distinguished from the so-called neurogenic OH, which is a damage to the autonomic nervous system, either in the afferent branch, in the central autonomic component of the autonomic nervous system, like it happens in multiple system atrophy mostly, or in the afferent autonomic branch, like it happens predominantly in Parkinson's disease and dementia with Lewy bodies. So, where to do this exercise, distinguish between neurogenic and non-neurogenic OH? Because non-neurogenic OH is a potentially reversible condition, for example, if due to drugs or dehydration, while neurogenic OH is a chronic condition due to a damage of the autonomic nervous system and can be only treated symptomatically. How to operate this distinction? A very important thing is to have a look at the heart rate behavior upon standing. If the baroreflex is impaired, like in neurogenic OH, we won't have a compensatory increase in heart rate when there is a systolic fall in blood pressure. And if this ratio indeed is below zero point 0.5, we have a strong clue that there is a baroreflex impairment in a person, the person we are examining. And this was in fact the case of this librarian. He had a very small increase in heart rate despite a severe fall in blood pressure, making a 0.125, which says this is neurogenic OH. In the autonomic function lab, we also perform additional tests like the Valsalva maneuver, and this, as you see here, shows a missing blood pressure counterregulation and delayed blood pressure recovery, ultimately also showing a baroreflex impairment and confirming the diagnosis of neurogenic OH. However, in this case, back then, the clinical neurological examination was unremarkable, and so he was diagnosed with pure autonomic failure. Pure autonomic failure was a disease entity described almost 100 years ago and defined by the presence of idiopathic, so neurogenic OH without a known cause, sometimes more widespread autonomic failure, but no other neurological signs. Due to the fact that phosphorylated alpha synuclein aggregates were found both in the peripheral nerves of people with PAF and sometimes in the brainstem, for many years we thought that pure autonomic failure is alpha synucleinopathy, like Parkinson's disease or multiple system atrophy, limited to the autonomic nervous system. However, this case came back 1 year later for routine follow up and he reported vivid dreams, and also his neurological examination was also changed. So let's have a look at here at this video.
Jänner, Februar, März, April, Mai, Juni, Juli, August, September, Oktober, November, Dezember. Mit der linken Seite. Gut, mit der linken Seite. Gut, die andere Seite.
So, as you might have appreciated, the voice tone in this person was what we would describe hypophonic, and his movement on the left side of the body was lower compared to the right side. So, indeed, we now know that P in pure autonomic failure is not pure at all, but in some people may mean premotor state of Parkinson's disease or multiple system atrophy, or the precognitive stage of dementia with Lewy body. Indeed, we now know that people with pure autonomic failure phenoconvert or so change their clinical presentation to another alpha synucleinopathies of around 5%, 5% every year in an equal proportion either to Parkinson's disease or dementia with Lewy body, which are diseases characterized by neuronal alpha synuclein aggregates, or to multiple system atrophy, where the aggregates mostly develop in the oligodendrocytes. So we performed some additional examination in this person, trying to understand um, where the journey was going on. We found that he had a postganglionic sympathetic denervation, so actually more typical for Lewy body disorders. His cerebral MRI was unremarkable, especially we did not find a putaminal or olivopontocerebellar atrophy, which you would expect for MSA. That scan revealed dopaminergic denervation as we expected, looking at his movements. Um, we suspected that he had a REM sleep behavior disorder due to these vivid dreams. He had an anosmia on a smell test, and so we concluded this was a Lewy body disorders beginning with pure autonomic failure. We indeed now know that sometimes Lewy body pathology resulting in Parkinson's disease may first develop in the body, so in the cardiovascular system and the gastrointestinal system, before proceeding to the brain, and may later on manifest with the so called noradrenergic subtype of Parkinson's disease. And there are hypotheses that in multiple system atrophy, sometimes the disease may likewise begin in the sacral spinal cord, so not in the brain first, as we used to know, but in the body first, in the sacral spinal cord. And this might be the reason why people with MSA develop erectile dysfunction or bladder disturbances some years before developing the full clinical picture of multiple system atrophy. Okay, but then in light of this recent understanding, should we better use the term isolated autonomic failure instead of pure autonomic failure? Likely, yes. But what does this imply for clinical practice? The implication is very important because now imagine the natural history of MSA and imagine that you have um, a disease modifying candidate and you're able to apply this very early in the disease course, then it is likely that this disease modifying candidate is able to impact on the natural history of the disease. But The same disease modifying candidate applied when most of the disease has manifested and neurons have degenerated won't likely have any effect. So research is moving in the recent years in the better understanding which are the predictors of phenoconversion from pure autonomic failure to either Parkinson's disease or premotor MSA. And so we now know that the presence of REM sleep behavior disorders, which are these vivid dreams with kicking out while sleeping and submotor signs, might indicate both so PD and MSA, but impaired function and an overall milder forms of autonomic impairment do rather point towards Parkinson's disease. On the other hand, a more severe urinary and gastrointestinal dysfunction and a so-called preganglionic or central pattern of autonomic dysfunction points towards MSA. Of course, research is very active in this field and is not only focusing on clinical biomarkers but also structural neuroimaging, functional neuroimaging. Indeed, normal cardiac dopamine PET has been shown to predict phenoconversion to MSA, and likewise at skin biopsies, the density, distribution pattern of phosphorylated alpha synuclein aggregates and associated neuropathy can distinguish between PD and MSA. And we also have very promising biomarkers in the CSF, so with alpha synuclein amplification assays and neurofilament light chain, and first evidence that we might be able to see this alpha synuclein seeding amplification and different conformation of alpha synuclein aggregates also in the serum of people with MSA compared to Parkinson's disease. So all this evidence has been indeed received in the new version of the MSA criteria, for which the research criteria for possible prodromal MSA have been devised. So these criteria have been devised for research purposes exactly to reflect this recent understanding in the natural history of MSA. So, which are the features? Essentially, a person with a sporadic progressive adult onset disease, so above the age of 30, presenting with either isolated REM sleep behavior disorder, which should be proven at polysomnography, neurogenic orthostatic hypotension, as we discussed at the beginning, or urogenital failure, that means sexual dysfunction plus voiding difficulties with post-void residual volumes or urinary urge and incontinence, subtle Parkinsonian or cerebellar features, and no exclusion criteria which might point towards Parkinson's disease, like it was the case in the librarian I showed you with some anosmia or abnormal MIBG, scintigraphy, or other features suggesting, for example, dementia with Lewy bodies with early cognitive impairment or supranuclear gaze palsy pointing towards, for example, progressive supranuclear palsy. But exactly in this case, doctors might wish to go for additional examination, and these are some which can be considered to refine the differential diagnosis. Now, what happens once we have diagnosed multiple system atrophy? So, if we are good enough, we diagnose MSA as soon as it manifests, and we start treating it symptomatically. So, we during the clinical follow-up, we start treating symptoms as as long as they develop, and indeed until we cannot cure multiple system atrophy, which we cannot unfortunately do at present, we should strive for the best possible care. However, which is the goal of this symptomatic treatment? Warrant autonomy, warrant quality of life, and prevent life-threatening events in people with MSA, such as injury or falls, syncope, hypertensive emergency, urosepsis, choking, aspiration pneumonia, malnutrition, and also sudden death. However, at some point, disability, at least as long as we have experienced this, so becomes so severe that geographical and physical barrier arise for the people to living with MSA to go and reach the center for their follow up, or maybe in the outpatient setting, what the doctors can offer is not enough to solve the problem which the person living with MSA has. And sometimes what we experience is that we lose people with MSA to follow up. So this is the point of view of the doctor. The point of view of a person living with MSA is that exactly when the disease becomes more severe, a less medical support is offered. And this was a very unsatisfying condition until now, which was worsened by the COVID pandemic, where many services had to be shut down to prevent the pandemic spread. The pandemic, however, also had some silver lining, the pandemic cloud, and this was the increase in telemedicine use in clinical practice. So the telemedicine momentum. We saw, in fact, that while only one third of centers were practicing, autonomic centers were practicing telemedicine before COVID, then 70% did this afterwards, either with phone calls, sometimes video calls, but also remote device monitoring. And both and doctors agreed that while the telemedicine visit might be suboptimal for first visit, so if you never met a person, it is very difficult to cancel this person in a telemedicine setting. But if you already know this person and which the problems basically are, then telemedicine is a very effective tool, which is enough satisfying both for physician and patients. And based on this, we asked and received major funding from the Austrian Science Fund for medical decision making in MSA. This was the kickoff meeting of this team of researchers who is indeed focusing on investigating the efficacy of a multidisciplinary personalized model of care with integrated telemedicine and mobile palliative support in abating these physical and geographical barriers which mount between people with MSA and their doctors in advanced disease stages, ultimately ameliorating the quality of life of people living with MSA and their caregivers throughout the disease course. The study is ongoing here in Austria, and we hope we will be able to report you on positive results in the next year. This was my last slide, but I would like to take the occasion to thank all the hard work of the Innsbruck Dysautonomia Center, of the Innsbruck Parkinson Unit, of our collaborators worldwide, and of course of the support of our funders. Thank you.